Continuation with our ECG classes. So we had one ECG class last month, and then we had one more on hypertrophy this week by Dr. Sunita. So now today we are going to do the electrical axis determination. So as we understand, the axis determination is predominantly for the QRS complex, but it's also for the P wave and the T wave. And first of all, we will understand the QRS complex axis determination. And for this, we need to understand the basic factor that there is a difference between the LV and the RV dominance starting from the fetal life to the neonatal period to the infancy to the adolescence. So if we consider the left ventricle and the right ventricle weight ratio, it is somewhere around 0.8:1 at birth. That means that the right ventricle is dominant, and then it becomes 2:1 at 6 months, and then it becomes 2.5:1 in adults. So this is a slow transition from RV dominance to LV dominance in adolescence. Now the RV dominance in infancy primarily gives rise to the Qrs axis, which is right and anterior in younger babies. So the rightward axis is something which we understand from the frontal plane, and the anterior and posterior axis relationship we understand from the horizontal plane. So we will see as we move forward, how do we understand right, left, superior, inferior in the frontal plane, and anterior, posterior, left, right from the horizontal plane. And in the adulthood, it becomes leftward and posterior QRS axis. Somewhere in between, you have an intermediate axis where the ECG can be either ways. It can be somewhere having an RV dominance or a transition to LV dominance. Now QRS axis, or how do we decide the axis? So basically, what is QRS axis? It's the mean or the dominant direction of all the vectors which are expressed in the ventricles. Now as we understand that the activation of the ventricle is synchronous in the sense that it starts from the endocardium to the epicardium at multiple points in time, at the same time. And these vectors are in different direction, and hence we need to understand what is the dominant direction of the vector. And this understanding happens in the frontal plane leads primarily, and it's much more reliable in the frontal plane leads. Now here you can see that initially the numbers 1, 2, 3, 4, 5, 6 denotes the time period. So initially you have the vector which starts in the interventricular septum, where you have some vectors which are from right to left and some left to right, but the dominant vector in the interventricular septum is from left to right. And after that you have from endocardium to epicardium simultaneously happening on both the sides, the RV and the LV. However, because in an adult heart you have the left ventricle which is dominant, the predominant vector is then expressed from left to right. So you can see here that initially you have a right to left axis, and then you have a left to right. So the initial part of QRS complex is going to be from left to right, and the terminal part of the QRS complex is going to be from right to left. Now, as we understood in the last class that this is the frontal plane, and we have the leads, the standard leads, which are 1, 2 and 3, and then we have the unipolar leads in the frontal plane, which is AVR, AVL and AVF. So we have totally 6 leads in the frontal plane, and these 6 leads give us an understanding about the superior, inferior and right leftward relationship and the axis. Now remember that this, when we say that lead 1 is positive here, lead 2 is positive here, AVF is positive here, lead 3 is positive here, AVR is positive at -150 and AVL is positive at -30, this positive negative poles, this positive negative degrees have nothing to do with the positive negative poles of the leads. So both are very independent, and here we can understand that our leads, the denotation starts from 0 to 180 degree positive and then 0 to 180 degree negative in the superior aspect. So lead 1 is positive here and lead 1 is negative here. Similarly, AVR is positive at -150 and it's negative at plus 30. So this is how the nomenclature is divided. So based on that, we can understand that every lead has a positive and a negative segment to define their polarity. For example, lead 1 is at 0 degrees. That means that everything which comes in this hemisphere is positive and whatever comes in this hemisphere is negative. Similarly, if you take lead AVF, and it is at 90 degrees plus 90 degrees here, whatever comes in the lower half quadrant is positive for AVF and whatever comes in the upper half quadrant is negative for AVF. Similarly, if you take lead 2, which is located at plus 60 degrees, this part is going to be the positive polarity and this part is going to be the negative pole. So with this understanding, now we can have certain basic concepts that there are leads which are perpendicular to each other, and this understanding is important when you determine the axis. So you have the lead 1 and the AVF which are exactly at 90 degrees. Similarly, you have the lead 2 and AVL which is at 90 degrees. And then you have the lead 3 and AVR which is at 90 degrees. So what does it mean if it's at 90 degrees? If a particular vector is directed towards lead 1, then the net amplitude is going to be with a maximum positive deflection here. And if you take a lead perpendicular to that lead, then it's going to be equiphasic in lead AVF. And hence we understand that the vector which is parallel to a lead, you will have maximum positive upright deflection. And a vector which is perpendicular to a particular lead, then you will have an equiphasic deflection. How do I decide about the positivity or negativity? For every lead, whenever you have a QRS complex, you will have to decide the net amplitude by subtracting the negative deflection from the positive deflection. So with that understanding, you will get a net vector which will be a particular number, and that number you can plot, for example, in a chart which is very similar to the ECG paper to get the exact axis. We will see in the subsequent slides. So for example, you have this grid sort of an understanding here between the lead 1 and AVF. Then let's see how do we decide. So for example, you have a QRS complex in lead 1 which is where you have a dominant R and a small s. So you will get the net amplitude of QRS by subtracting the S wave from the R wave. And for example, the net amplitude came as 5. So this is the point where you have 1, 2, 3, 4 and 5, and then you draw a line perpendicular from this lead. Similarly, at AVF, for example, you have a dominant R and a small s with a net deflection of 3. Then you will have a point here. So the junction where these two perpendicular lines will meet is going to be the point which decides the axis, which is 60 degrees. So this is how you can use a grid sort of an understanding to plot the numbers of the net amplitude of QRS complexes and then draw a line perpendicular from that lead. It's not necessary for you to take only lead 1 and AVF. You can take lead 1 and lead 3 or AVL and lead 2. Anything which you feel comfortable to draw the lines perpendicular to that particular point. Now, based on this, you will have the quadrants which will give you an idea fairly which quadrant your QRS axis is located. For example, you take lead 1 and AVF. So in this figure, we have taken lead 1 and AVF, but you can take any two leads. And in that, you can understand that lead 1 is here, and hence we decided that all positivity will come in the lower half of the hemisphere. And for AVF, this is positive, and hence all positivity will come in this half of the semicircle. And hence, if you lie in this quadrant where the lead 1 is positive and AVF is positive, then your axis is between 0 to 90 degrees. Similarly, if your lead 1 is positive but AVF is negative, as we understand, the upper half is negative for AVF. So if your AVF is a negative net amplitude, then your QRS axis is going to be between 0 degrees to minus 90 degrees. Similarly, if you have lead 1 negative and AVF positive, then you are going to be between plus 90 to 180 degrees, that is right lower quadrant. And if it's going to be negative in lead 1 and negative in lead AVF, then it's going to be right superior quadrant, that is between minus 90 degrees to plus 180 degrees. Now this locating quadrants is the first initial step which could help us to concentrate in this area, and after that you can look forward to the further ways of fine defining your axis. So as we understand that if we have a maximum deflection in a particular lead, then you are going to have either a positive or a negative maximum amplitude in that lead. For example, if this is AVF, so AVF is positive here, and if you have a Qrs axis which is upright in AVF, then you're going to have this sort of Qrs complex and your axis is towards AVF. And if you have it towards the negative pole, then you will have a negative Qrs complex in AVF, but you will have maximum deflection in that direction. Whereas if I have my Qrs axis a little tilted, then it's going to be a mixed picture of positive and negative components of Qrs complexes. In contrast to this, if I have my Qrs complex which is perpendicular to the lead AVF, then I will have a small equiphasic complex, and this is known as a null deflection. So remember, if you have a small equiphasic complex in a particular lead, then your Qrs complex is perpendicular to that lead. And if you have a maximum deflection in a particular lead, then your Qrs complex is towards that lead. It could be towards the positive pole if it's a positive deflection, and it could be towards the negative pole if it's a negative deflection. So we will just summarize what we learned so far, that for locating a Qrs axis, first of all decide which quadrant you are having using the leads 1 and AVF and seeing the positive negative Qrs complexes in these two leads. Once you decide that it's in a particular quadrant, you see which lead in the frontal plane has the equiphasic Qrs complex. So if you have an equiphasic Qrs complex at 90 degrees, then your Qrs is going to be perpendicular to that lead. That means that it's 0 degrees. So then you have a little more stronger focus where your lead is Qrs axis is. And after that, the third point is you find the lead with the greatest Qrs deflection, either positive and negative in the predetermined quadrant, and then you know that your Qrs axis is going to be close to the positive or the negative limb of the lead. Now these 3 points, if you do, you will be able to define your Qrs axis fairly accurately, not necessarily that you have to use your grid system for fine-tuning this. Now, these things can be used. So far, whatever we spoke about the Qrs complex can be used in a situation where you have a dominant vector. But think of a situation where you have a Katz-Bachel phenomena, where you have the Qrs complexes in the frontal leads which are equiphasic. So when you have an equiphasic thing, and if your final net amplitude is coming close to 0, then it's going to be difficult for you to define the Qrs axis. So in that situation, the concept of two-vector plot comes, wherein you find the Qrs axis of the initial Qrs complex, and then finally you find it for the terminal Qrs complex. So in that situation, you will have to calculate two axes, the initial and the terminal. So initially you see the QR complex net amplitude, and then you plot it, and then you find the S wave axis, and then you plot it. So many times you will have a wide variation in the two. For example, the initial will be in the left lower quadrant and the final will be in the right upper quadrant. But that's how you can find the axis when you have equiphasic Qrs complexes in most of the frontal leads. Now, once you decide the Qrs complex, what is the implication? So we understand that a normal Qrs in an adult is in the left lower quadrant, and it's usually between 0 to 90 degrees. However, in a younger age, as we decided, there is RV dominance, and you can have a correlated rightward axis in a newborn, which can actually go up to 120-130 degrees in a newborn and up to 120 degrees in an adolescent. So you can have it in the right lower quadrant in younger children, and in an adult it's between 0 and 90 degrees. Any axis which is in the left upper quadrant is defined as left axis deviation, and in the right lower quadrant is defined as right axis deviation. In the left axis deviation, if it's closer, it's from 0 to minus 30 degrees, then it's defined as left axis deviation, which is slight. And if it's minus 30 to minus 90, then it's defined as a marked left axis deviation. And when it's in the right upper quadrant, it is defined as a northwest axis. So it's the northwest axis or superior rightward axis. So there are situations where you would see a leftward axis, that is the left superior quadrant, which could be associated with left ventricular hypertrophy, left bundle branch block, or an accessory pathway. And you can have a northwest axis in children with tetralogy of Fallot or a right bundle branch block. Also, we understand that in structural heart diseases like, for example, you have an inlet VSD or a muscular VSD, you commonly have a leftward axis. If you have tricuspid atresia, you can have a leftward axis. And for that matter, if it's a VSD, pulmonary atresia, DORV, you can have a rightward axis, which could be also in the northwest region. So this is the implication of the Qrs axis, which is abnormal. Now with that understanding, we move on to the P wave axis. The determination of P wave axis is done in a similar way of Qrs. Now as you understand, the Qrs axis defines the ventricular depolarization, whereas the P wave axis represents the direction of atrial depolarization. So finally, it gives us an idea where the pacemaker of the heart is situated. Now, because the normal pacemaker is the sinus node, the normal P wave axis is downwards and leftwards. So that means it's between plus 40 to plus 60 in the frontal plane. We are not talking about the horizontal plane. If you consider the horizontal plane, then we will see how the P wave axis is there in the horizontal plane. And as we saw the P wave understanding in the last class, we know that it's more directed anteriorly. So in the frontal plane, the P wave axis is downwards and leftwards, and any axis which is less than 45 degrees for a P wave is defined as a left axis deviation, and any axis which is more than 70 degrees is defined as a right axis deviation for the P wave. So whenever the P wave axis is minus 32 plus 70 degrees, it can happen. You can have variable P wave axis in a congenital heart disease. When the P wave axis is not between 40 and 60, you need to think of a ectopic P wave or a nodal rhythm. Typically, a nodal rhythm will have a superior P wave axis. And if you have a P wave axis between 120 and 150 degrees, this can happen when you have atrial situs inversus, which typically happens in a mirror image dextrocardia. Remember that if you have a P wave axis which is rightward and downwards, what you see here in this numbers, it can also happen if your arm electrodes are reversed. And how do I differentiate that? I can differentiate these two between atrial situs inversus and my arm electrodes which are reversed using the precordial leads. So in a precordial leads, I will have a reverse QRS pattern in the mirror image dextrocardia, whereas in the arm leads reversal, I will not have a reverse QRS pattern in the precordial leads. So remember, you have a P wave axis which is abnormal. It can happen in a congenital heart disease. It can happen in an ectopic pacemaker, atrial ectopics, nodal rhythm, or it can happen when my atrial situs is ambiguous or reversed. Similarly, you have the T wave axis understanding. Now, the T wave axis, as you understand, it is the ventricular repolarization. So the T wave axis represents the mean vector of ventricular repolarization. And normally it is between 0 to 90 degrees, which correlates with your QRS axis. So remember that the QRS axis and the T wave axis is usually in the same direction. Now coming to the T wave understanding, in a newborn we know that the RV is dominant and hence the T wave morphology and the axis is different compared to an adult. The T wave is usually upright in the first 3 days of life and then it becomes negative starting from the 4th day to few years. Those few years can range between 3 to 8 years of life and after that it becomes upright. So the first 3 days the T wave is negative in V1. It's positive in V1 and then it becomes negative from day 4 to 3 to 8 years of life and after that it becomes upright again. So presence of a negative T wave in V1 in majority of the childhood period does not indicate an abnormal T wave axis. Also remember that when you have a problem in the repolarization, then the T wave axis is going to move away from the region of pathology. So for example, if I have a problem in the apical part of the ventricular myocardium, then my T wave axis is going to move away from the apex. And when do I see an abnormal T axis? When I have a strain in the myocardium. So any ventricular hypertrophy with a strain, I'm going to have an abnormal T wave axis. Or if I have myocarditis, pericarditis, myocardial ischemia or conduction disturbances, then I have T wave axis which is abnormal. And then with that understanding, we need to come down to an important concept of Qrst angle. So Qrst angle means what? It relates to the correlation between ventricular depolarization to repolarization. And normally, as we understand, the Qrs axis and the T wave axis are closer to each other and hence your Qrst angle should not exceed 30 degrees. It should not be more than 30 degrees after 3 months of age. If Qrst angle is more than 60 degrees, Qrst angle is more than 60 degrees, then it's abnormal. However, the Qrst angle is less significant if the T axis is normal than if it's abnormal. So you will take into consideration the T wave axis individually and also the Qrst angle. If both are abnormal, then the significance is more. And as we understood in the previous slide, the Qrst angle can be wide in situations where you have left ventricular hypertrophy with strain. For example, you have severe coarse, severe aortic stenosis with strain pattern, or you can have right ventricle with strain, or you have myocardial dysfunction. So any myocardial abnormality, you can have a Qrst angle wide and the T axis abnormal. Now similarly, you have an axis for the ST segment. Now ST segment, as we understood, is a segment which is isoelectric and it's between the S wave, the end of S and the beginning of T. So it's the time duration which is between the depolarization of the ventricles and the repolarization of the ventricles. In contrast to the T axis, the ST segment axis goes more towards the surface of injury. So the T wave axis goes away from the injury point and the ST axis goes towards the injury point. For example, if you have pericarditis, it's most localized towards the apex, then the ST segment is going to be closer to the apex, whereas the T axis is going to be away from the apex. For example, in the right upper or northwest quadrant. So this is the significance of ST segment. So commonly you will see the ST and the T axis in opposite directions in a situation where you have an abnormal heart. I hope whatever we did so far is okay. Any doubts, please ask me. We are going to a little different concept from the next slide. So far whatever we understood was the hex-axial system. That means the frontal plane system. Now we are going to talk about a little on the horizontal reference system. Any questions from anybody? If no, then we can take questions at the end and move on to the next part. So why did we talk so much about the frontal plane? It is because the frontal plane understanding is much more reliable in terms of the axis determination compared to the horizontal system. So as we understand, this is the frontal plane and this is defined as the hex-axial reference system. It's hex-axial because you have 6 leads here. And then this is the horizontal plane where you have the horizontal reference system which has leads from V1 to V6. So this relationship, as you can understand, is more anteroposterior, whereas this relationship is more superior-inferior. In both the planes, you have a relationship which is left to right. And we did this last time, and we're just going to summarize that the way the leads are put on the chest, which are ranging from V1 to V6. In this, the angle between the two leads is 30 degrees and the angle between V2 and V6 is 90 degrees. So similarly, the way we used the leads 1 and AVF or lead 2 and AVL or lead 3 and AVR in the frontal plane, we can also use the lead V2 and V6, which are perpendicular to each other, to determine the axis in the horizontal system. So here you can see that the lead V2 is defining the anterior to posterior relationship, whereas the lead V6 is accurately going to be giving you the understanding of left-right. So for example, if you have a lead QRS completely positive in lead V2, you know that it's completely anteriorly directed QRS axis. Whereas in lead V6, if you have a negative complex, you know that it's more of rightward directed QRS axis. So similarly, how we understood in the frontal plane, let us see what happens to the positive negative polarity here. So you have the lead V1, which is a little to the right of the midline. And here you can understand that this part is going to be completely positive, whereas the back part is going to be completely negative. Similarly, in V2, the front half is going to be strongly positive and the back half is going to be strongly negative. Similarly, for V6, which is here, you have the left quadrant which is going to be positive and the right quadrant which is going to be negative. Now, how do I denote this QRS vector in the horizontal plane? It's important for us to include the understanding of anterior-posterior relationship in the axis determination. And for that, you could check one of the leads or two leads, dominantly V2 and V6. So if lead V2 is positive, then you know that your axis is predominantly anterior, and that's how it is denoted. This is how it's denoted. And if your vector is completely negative in lead V2, then you know that the primary axis is posterior. And if it's equiphasic in V2, then it is an intermediate axis in terms of anterior and posterior relationship. So this is an important understanding. We were talking about the P wave. So the P wave is dominantly directed if it's positive in lead 1 and V2. We know that the P wave vector is primarily anteriorly directed. So this is what is an additional understanding compared to the understanding that the P wave is downward and leftward, inferiorly and leftward axis. It's also having an anterior axis. Now, this is just to summarize here in this slide. You can see that there are lots of differences in the axis of QRS, starting from the newborn period to adolescent, where you can see that your axis can go usually up to 140 to 160 in a newborn, whereas by 3 years of age, it's usually less than 90 degrees. And this is reflected in your RS ratio, etc. So you have a dominant R wave in the right precordial leads in a newborn, whereas you have a dominant left R wave in left precordial leads in an adolescent child. The S wave, similarly, you have it more dominant in the left precordial leads in a newborn, whereas in the right precordial leads in an adult. So the RS progression, as you understand, we discussed about this RS progression and RS ratio in the last class, where you know that your RS ratio is going to be dominant in the right precordial leads in a newborn compared to the adults. So you would use the understanding that the RS progression is reversed of an adult, And the RS ratio is usually more than 1 in a newborn, in contrast to less than 1 in an older child. Also, the T wave understanding is very important. It can be upright from day 1 to day 3, and then it becomes negative from day 3 to 3 to 8 years of life. Whereas here, after 16 years, it cannot be negative. And similarly, you can have Q waves in a newborn in the right precaudal leads, whereas in an adult, you have it in the left precaudal leads. Normally, anything less than 5 millimeters of Q waves in the left precaudal leads for an adult is considered to be normal. So with this understanding, let's do 3 or 4 exercises to determine the axis, and it's actually going to be very easy. You can all use your chat box now and write the answers in the chat box. So can you name the leads in the figure and write down which 2 leads are perpendicular to each other? So which are the leads which are perpendicular to each other? You can write down your answers in the chat box. Lead 1 and AVF, yes. Any other leads? Any other leads which are perpendicular to each other? Lead 2 and AVL, yes. And lead 3 and AVR, yes. So that's right, and you can use any of the leads. I personally feel comfortable using 1 and AVF because they are exactly perpendicular to each other, and it's easy to plot the axis in the quadrant. Most of the axis will be in the left lower quadrant, so I feel lead 1 and AVF is comfortable. So now we will go question by question. You just have to tell me whether this is true or false. Qrs axis of more than 90 degrees is considered abnormal at 1 month of age. So you can just write your answers in the chat box. Do you think it's abnormal at 1 month of age? No. False. Yes. Correct. We come to the next question. The P wave axis of 120 degrees can be seen in the frontal plane if the arm electrodes are reversed. True or false? Yes. Yes, so it's true. You can have 120 degrees. So whenever you have your P wave axis which is not normal, make sure that your arm electrodes are correctly put. Coming down to C, wide Qrst angle can be seen in aortic regurgitation. So you have a wide Qrst complex of more than 60 degrees. Can you see it in aortic regurgitation? Okay, I would say that commonly it is seen in stenotic lesions compared to regurgitation lesion. So you can have a dilated left ventricle with a normal LV function. You will not have a wide QRST. Wide QRST commonly goes with LVH. Yes, that's true. Secondary to an obstructive lesion commonly like aortic stenosis or systemic hypertension, etc. Coming down to D, presence of QR in V1 in a newborn suggests right ventricular hypertrophy. Normally, you should have Q waves in V6. If you have Q waves in V1, it suggests right ventricular hypertrophy. Is it right or wrong? Okay, so I'm getting lots of answers as true. Can you tell me which ventricle is dominant in a newborn? It's the right ventricle. So if you have Q waves in a newborn in V1, it can be an acceptable RV dominance and it does not suggest RVH. But remember that if you have a pure R wave which is more than 10, then it is abnormal. Presence of QR. I'll go back to that slide. You understand? We just summarized our points. So see here, you can have R wave dominant or a QR pattern in V1 which suggests RVH. Yeah, so you can have R wave dominance, but pure R more than 10 millimeter is more reliable of right ventricular hypertrophy. And the last is T wave in V1 must be upright in an adult. True or false? Yes. So true. That's right. T wave in V1 must be upright in an adult. That's right. So for us, usually between 3 to 8 years, it becomes upright, but up till 16 years, you can't tell that it's not normal. After 16 years in an adult, you would say that yes, it needs to be upright. Okay. So can you all see this? Sorry. Okay, just a minute. I think it has skipped some slides. We'll just go on to this. Can we decide what is the P wave axis and the QRS axis in this ECG? So let's see what's the P wave axis in this ECG. So first you can decide the lead 1 and AVF, whether it's positive or negative. Decide your quadrant. So I get an answer both in normal quadrants. Yes. So how do you decide that? P wave axis is in the left lower quadrant, and is it equiphasic? Do you have equiphasic P waves anywhere? You don't find it. It's dominantly positive in lead 2. So you would say that it's around 60 degrees. Agreed. And the QRS is also positive in 1 and AVF. And is it equiphasic QRS anywhere? We don't find it. And then you find it strongly positive in lead 2 and AVL. So it's strongly positive in lead 2 and not that strong positive in lead 3. So again, your axis is your axis is around 30 to 60 degrees. Okay, here can you find out the P wave axis? So I'm getting different answers, 30 to 60 degrees, upward, left. Yes, because see this, AVF is negative and lead 1 is positive. So it is left superior quadrant or its left axis deviation. Further, if you go in and see, it's negative in lead 3 and it's negative in lead 2 also. It's positive in AVL. So it's in the left lower quadrant. So left upper quadrant, sorry. So the axis of the P wave is superior, and this can commonly happen if your P wave starts from lower part of the atria. So it's a superior axis in the left upper quadrant, left axis deviation. Okay, can we find the QRS axis and the T wave axis here? So I have the answer. This is the QRS is left axis, the T is right, around 0 degrees. That's perfectly correct because AVF is equiphasic. If AVF is equiphasic, the axis is going to be in this direction with a positive lead 1. It's expected to be surrounding this area. So it's around 0 degrees. And the T wave axis is, okay, so I get an answer of -10. That's good, because see here the AVL is strongly positive. If you see, most positive is AVL along with V1. So it's going to be between 0 and -30 degrees. I agree. So that's the QRS axis. So the T wave axis We're talking about the T wave axis in the frontal plane. So you can see here the T wave is negative in lead 1 and it's positive in AVF. So which quadrant we are lying? This is in the right superior quadrant. Now if you see, lead 1 is negative and the AVF is positive. So it's the right lower quadrant. I'm really sorry, right lower quadrant. And then you have it positive in lead 3, maximum positive in lead 3, and negative in AVL. So negative in AVL, positive in lead 3. So your T wave axis is right lower quadrant. Yes, that's right. So your T wave axis is around 120 degrees and your QRS is 0 degrees. The T wave axis, Qrst angle more than 60 degrees, both of which are abnormal. So you can see here, in addition to that, your horizontal plane, and you can see where is your T wave axis and QRS axis here. So you can see clearly that your QRS is negative and T is positive. So both of which are going to come in different quadrants. So if you see your lead V2, your QRS is dominantly negative. That means your forces are more posterior, and T wave is dominantly positive, so it's more anterior. So you can see here also in this plane, the horizontal plane also, your Qrst angle is wide and your T wave axis is abnormal. Okay. Can we decide the QRS axis here? In the frontal plane, okay, so lead 1 is positive and AVF is negative, so it is left superior. You can see here the AVL is dominantly positive. Yes, so it's left axis deviation. Your lead 3 is dominantly negative, so it's going to be around minus 30 degrees with a dominant left ventricular hypertrophy. So this is a situation where you have LVH and superior left superior axis. The QRS axis is superior in the left upper quadrant with left ventricular hypertrophy. So this is left axis deviation with left ventricular hypertrophy. Okay, so I think we will end our session now. Yes, right inferior. Right inferior. Just 1 minute. Palak, why do you think it's right inferior? No. Okay, left superior. Yes. Okay, so I think this is the end of our discussion today. Any questions, please feel free to ask.